closing my laptop. I'm having trouble with the internet as is, man.
It's because he's not directing on his back.
Joe, my battery was at 100%. You closed it, now it's at 93. Thank you.
Have
The biggest thing is that there are USB A. If Joe can't have his computer, we can. Alright, yeah. That's it. I'll take it. They're bringing those back. And then the charging port's gonna be back to the MagSafe. No, because he's just gonna come and push you over or some shit. That's even worse. You know what? I'd rather him push me over than that. For our years, you have how real protected the other ones, Halo's has no mag. What? Yeah, he's gotta have something special on that hard drive.
Let's check the cookies on there, pal.
Yeah. There's 2017 is the USB and the Type-C charging port, and then even the 20s.
So explain yourself. Makes you sound guilty.
Type-C. They're going back to the exam.
I like that.
Yeah, tell me about it. So, it's gonna be worth the wait after you know stuff. But the
Professor, when do we expect to have our first exam or an midterm test?
Late April, early March.
Okay, just
Halfway through this month.
Okay.
I'll try and remember look at a calendar.
Okay.
Get a better answer.
No problem.
I'm not even a part of this, and I think
Just curious.
it's just happening.
So we pick it. Oh, there.
Did you see Dave Portman getting kicked out?
He was there again.
Yeah. He's there every year.
I can see that.
It's hard to they use it.
We have to face there. He's there. He's gonna start talking with Marshall.
I'm like, that's not the same.
Not the same. Sorry.
Because I was just kidding, but
Yeah.
your dog will.
How's the day?
He's not done.
Literally.
His car battery died. Oh, so his mom.
Now it's weird that Honda, Ford, and every other car dealership is running. I'm not gonna lie. When I drove my Honda's CR-V and it got cold outside, that battery died like it was his job. Oh yeah.
Subaru's been good to me.
That was actually one of the main reasons I started waiting
Yes.
on that. Just like my brothers did.
I
Just
literally.
like the second it got chilly,
So funny.
we give up. Like the French.
Some of them were like just way too accurate, and I'm like, I don't understand where you were coming from.
It's a good historical joke, man.
That's nice.
Yeah, it follows iPhone modern, like the square genetics and you're gonna have the best.
I mean, the one thing I like about servers so much is like they do last a long time. I had mine
Never
for
change. I
like
like reading about it.
6 years.
A lot of cool stuff.
I mean, it is kind of like
Supposed to.
starting to like freak out a little bit, but I mean, none of them are
A lot of cool stuff
technology.
Yeah. Yo, Face ID.
Face ID on the laptop?
Yeah.
So
Oh man, that's
Yo, I'm hurting bad today.
yeah, I have to tell myself it's worth it. Can't stand this.
yeah, no, but it's always, I used to do that on my phone.
How's
Like,
it
always
going?
the phone.
That's like it's like almost worse. Yeah, exactly.
So I'm
Like
just kidding now.
You know, I'm kind of glad like Kevin's not here, man. Like I'm kind of getting tired of him.
Hey, we're not yet.
Yeah.
Put this away. Save it.
The kid's a real loser. Yeah, Kevin's just like he.
I
You recorded
don't
it?
like them there. I have them because it's just easy.
He's on. He's down there.
I don't
Probably
specific.
just one back to
I
sleep.
don't like a lot of them, but I like to.
He's like, oh man.
Actually,
Oh wow, so you got the one.
yeah.
I have
Was it a two-part thing or like did you
I
want
just
one more, not the
didn't
other?
have patience or time or money or the timing.
Yeah, basically.
Oh,
Asking you.
You broke even.
Yeah.
more about like if you're having fun.
Dude, that's the
If
move.
you're getting stressed out there, that's the
Since I did semesters, I have different folders, I have semester one and two.
and those are usually a big payout, right?
Yeah, those.
But that's what I have the laptop for. So I don't really have it right now. I'm gonna try, probably Thursday.
That's a bad way to go. That's
Third semester.
I'm excited to see what they send me.
my
I
habits
go
are,
find it.
this is more from my education.
Actually, you know
Yo,
what
what
I'm
if they
doing?
could give me math this time?
You know what
Did
I'm
you guys
doing?
get your chargeback or your?
Yeah,
I used to go to
apparently, Sashi got a lot of money. That's
I had that song in Lake, I was like the next guy.
Oh my God, like 16 then when I got my
Fell on you.
I'll make like small bets.
Yes. The answer is yes. Well, like, you vouch for like, you put in 30, the chance.
You're asking me to do
Yeah,
a lot of
just
my
like that. Like for instance,
December.
Yo, I've enjoyed caffeine. Yeah.
That doesn't work
I don't drink caffeine for like that. I drink it for the taste. So I basically drink just
The moment my feet hit the ground, I'm like,
That's great.
the only time I take my feet on the ground.
I feel like now it's just become part of my routine. I don't actually like need to drink it. I just drink it for the.
Do you guys still get new student
Yeah.
photos?
Yeah, what is with that?
I've been a student since
I
December.
want.
I'm not a new student anymore.
I've been doing this for the last whole year and a half.
Did you do your progression?
What?
Did you do your
Oh, I
progression?
can see.
Oh.
Very good to see you, so
I mean,
I watched.
I had to redo my redo my course.
Yeah.
No, but I'm saying like for the year that the stuff.
Yeah.
Oh, you didn't like that one?
I honestly thought you had to, which is why I read it. And then they were like, oh no, you can just try it like that. Well, the thing that was just what's the one like, I went down to house like that.
Yeah, that was mine.
Yeah, like it wasn't the same like side beach. So it wasn't also a full 20 minutes closer to the job.
I guess just because they had lost in early in the season. Brown wall.
It's not opening up the lane.
I guess I gotta be in the slot.
Which is why. South.
Yep.
You don't have to. That's how you're right. Somebody's serviceable.
Can you right click it?
Yep.
I'll try to hyperlink.
That's
Yeah.
nasty.
Open hyperlink?
Yeah.
On the button.
Carson wants us to be done to the Bears.
Yep.
Is that what you needed?
And that means
Oh.
BDN is going back to.
Bring it back, baby. Bring it back.
McWolf is coming back to recon and the first round pick. I don't think that's enough for Carson Wentz.
Yeah, get him out of there.
Honestly, Carson Wentz would probably be better on the Colts.
The Lions got 3 first round picks for Matt Stafford.
Yeah.
He's way older than Wentz.
But Matthew Stafford is also an excellent quarterback who's
Brett
played on
Stafford
all
is
football.
one of the best quarterbacks in the league.
I know, and I've
Get him out of Detroit.
I've said it on my podcast like
It's
2 or 3
still
times
sensitive.
that he
Like, I
literally
don't feel
wants
it,
to
but
go
the
anywhere else and
I
would
like
probably win a
You know
Super
the
Bowl.
Lions'
Like,
first
I was, like,
request
kinda like-
was Aaron Donald for Matt Stafford, and they shot that down real quick.
Do you think TJ Watt should have gone?
Yes. 100%. You let him understand.
The interesting,
I don't want to hear.
no, the only interesting fact about it though is that TJ Watt was pressured, was double teamed on I think it was 3% of plays.
Yeah, Aaron Donald was
That was
like
like
80.
Yeah, and he managed to still put up those numbers. It's disgusting.
Alright, sorry it took so long. Technical difficulties. How many people I got on one?
Yeah, we have 2 on there right now.
Okay.
One's car isn't working, the other one
Winter. Okay, 1 month. Lower extremity movements continue to be, again, reflex dominated, so if the child's moving around 1 month, it's pretty much reflex. Thrust arms and legs out in play. Remember that video of the normal child, the way it was spontaneous movement. Startle spontaneously, so sometimes they move in a certain direction, and that actually triggers their own motor reflex. Hands fisted to slightly open, so thumb's still in their palm, but start to come out. Rolls part way to side and returns, so starting to work on equilibrium reaction, and starting to get ready to roll one of the first milestones. And slight increase in head control, 1 month. Intellectual, alert about 1 hour, 1 out of every 10 hours. Has a vague and impassive expression during most of the waking time. Remembers objects that reappear within a couple of seconds. Cries for assistance. Have these fussy periods, certain time every night, or whenever it's going to be. Towards the end of the first month, quiets when held or when they see a face. So again, they're starting to learn how to self-calm. Pacifier. Remember we saw the baby got the pacifier, they calm down right away. Same thing, some other techniques. Fussy periods. So I remember my oldest son, it was like 6 o'clock. He was always like screaming and nobody knew why, but they just kind of come and go. And object permanence. Everybody took psych, right? You have to take, still as a prereq. Everybody remember object permanence? Anybody?
Was it, so let's say you're doing like the peekaboo game, he thinks like your face is gone and then it reappears. It's
Right,
where,
right, yeah. So it takes about a good 9, 12 months, let's say I have a baby and I have this, it's in their visual field, I drop it, to them it's gone. Okay, and then what's the next step? Drop it, they track it. And then I could put a blanket over it, and then it's gone. Next thing they know, you drop it, you put a blanket over it, they know that the blanket is covered in the object. Or, oh yeah, I left my teddy bear in the bedroom upstairs. So that's that object permanent. So the object is now permanent. I kind of know where it is, and it's mentally that's how I think of things. We'll talk about it. Yes.
Is the object permanence actually for 1 month? Because both my kids didn't master that until about like 7 or 8 months. So it's not like they're really going things around or is that just like
No, it should be, like I said, around 12 months. They weren't boys, were they?
they're boy, it's a boy and a girl?
Oh, okay. I said men just forget where everything is, but what was that?
You're saying how many months?
It's around 12 months. We'll do a whole thing. I just want to introduce it. So yeah, that's a little. I'm not getting that. Yeah. Burps 3 times, 4 times during feeding. Bowel movements, if they have, again, it's just stuff parents have questions about. So if they're breastfeeding, it might be a little yellow. If it's a bottle, it's going to be like a brownish clay colored. And if it's green, that's bile. So their gut's still immature, but still there's some things about bowel. Sensory motor. Stares at an object, doesn't quite reach for it yet, so only a month. They can see an object, but they just don't have the ability yet to go and reach for something. Coordinates eyes sideways when regarding light or object. So they're starting to work on a peripheral vision there. Remember rods and cones in your eye, right? So one's for the middle, the other one's for peripheral color. Can place object in hand, but will drop it quickly. So again, not much going on with the hand. A lot has to do with the thumb because it's really that cortical thumb still. Until it gets out here, it's not going to be very functional if it's in your palm. Roots for breast, even when not breastfeeding. So again, still driven by that primitive reflex, that rooting reflex. So component, prone, 1 month. So what do they look like prone at 1 month? Decreasing physiological flexion, so starting to lengthen out a little bit. Increase in extension. Maybe they'll extend head to 45 degrees. So again, this flexion and extension of the head, gonna get, anytime you get that muscle contraction, joint's gonna get closer together, you're gonna get proprioceptive input, all that's gonna help with eventual muscle control, especially head control. Weight bearing moves down to thoracic spine, pelvis is lower, elbows are behind the shoulder girdle, this makes it difficult to keep weight off the head. I said 95, I usually wear the surgical mask. Well, if I pass out, that's why. I can't breathe. Well, I'm working it a little bit. I guess I'm going to fall like this a little bit. Okay, opponent, supine. Gravity has a greater initial influence and extension, just that you're extended into the support surface. Body weight is more evenly distributed because flexion against gravity is more difficult than supine. So that's why it looks like they splayed out a little bit. Remember the two babies? The one was just couldn't control against gravity at all. They were flat on the support surface. And the other baby had his legs up and his arms up. So definitely less flexion. And pelvis cannot elevate and shift weight forward. So we're not there yet as far as the pelvis goes.
So when you say like pelvis is like has dropped lower, or pelvis like is that because of the physiological flexion that they're in? They're like kind of curved versus like when they start to progress, they start to like flatten out a little bit more.
Yep, so the hip flexors will start stretching and their pelvis will go down to an anterior tilt. Yeah, so they're just stretching out. Now we'll find my picture. Short way to get back there. I want to get to these things. Show it to the side. I'm going to go to those pictures of the baby. Okay, so again, newborn, physiologic flexion, 18R. If it's real big, it's a real strong one, this leg will be flexed more. Just kind of fall into gravity. Gets a little step reaction. And then 1 month. So it's still asymmetry, right? Just because they can't lift against gravity, the head's going to be turned to one side or the other and thrown. Maybe they can lift it up a little bit. And again, eventually these arms will start moving out now. So let's look at this picture. And again, when we look at infants, babies, where do we start?
Head.
And then we go to the trunk and pelvis, right? So proximal and then distal, right? So then we start with the extremity. So the head. Position. Turn to one side, right? Asymmetrical? Asymmetrical? How come? 1 month old? Can't do it yet, right? Not strong enough, don't have enough head control yet, they hold it in midline. Trunk, pretty flat. Extremities, what are they being driven by there? What's that?
Weight-bearing side is low.
Still on that one picture. So, look. Baby's got his head turned to the side. What's going on with the extremities?
Flexion on the opposite side,
And,
extension on the side he's looking.
yep, and what's that called?
ATNR.
Right, right. Asymmetrical, tonic, muscle, neck, driven by the head being turned, reflex. So he's going to hold it back. And again, looks like he's looking at his hand. And we put him prone. Lift the head a little bit. home fairly. Starting to flatten out, still flex hips, flex knees. Elbows are still back behind the shoulder. So he's got him in front a little bit. But again, asymmetry. Not strong enough yet to keep everything in midline. And a lot of it's going to be driven by that, by those primitive reflexes.
You can still say that they're in like radiological flexion, but it's decreasing flexor power from these hips.
Right. Yep. And they're starting to extend. So the hip is starting to stretch those hip flexors, but still have flexions hanging in there. All right. 3 months. What do you notice? This picture versus this one.
Mine's the head is pretty symmetrical. Both arms are doing the same thing, the legs are both doing the same thing.
So it's more symmetrical, right?
Aside from the head, yeah.
What else about the legs?
He's able to start to bring them up towards,
Right, so he can start working against gravity, right? So he's starting to have better control. But, went from a little asymmetry to symmetry. Yes?
Is that flexion against gravity right there, or?
This one?
Yeah.
Yes.
In supine?
Yep.
Is there such a thing as flexion against gravity from prone, or does that wouldn't happen?
Not yet, but it's coming. That's the more as he gets older and he gets better muscle control, he'll start being able to push up and flex it against gravity, come to a quadruped position. And what about this one?
His head, he's right at his head.
Okay, good, yep. So midline, right? Midline. Can hold his head in midline. And how's he doing that? What motion is he doing there? Goes with writing, but
Adduction.
it's got that, still with the head.
Extension.
It's got the chin tuck. Yep. So he's tucking his chin. That gives him better visual regard of the object that he's looking at. And what about the extremity? The trunk? Pretty flat, right? Against gravity. And the extremities? Symmetrical, right? But what's he able to do? So, hold something in midline, using 2 hands. And why is that nice? What do you think's next? What's a nice functional activity for an infant at that age? Holding a bottle, right? So he can put that bottle in his hands, 2 hands, holding something. Okay? Eventually you're going to have 1 hand holding something, put them together, manipulate objects, and we'll talk about that following motor development also. And this picture?
You can see his like arms are a little bit more extended out.
Where do we start?
Okay.
Yeah,
The woman's leg.
Extension.
extension,
starting
right?
to work an extension.
And what
Extend his
is that?
right.
Writing reaction. So he's getting his head up against gravity, he's working on a writing reaction. You start to observe his environment. And it's midline, right? It's not asymmetric, it's not turned to one side. Trunk,
Looks like he's in my eyes are terrible. Looks like he's in extension.
where?
Against gravity. Pushing
Where?
against gravity.
Yeah, where an extension?
Thoracic.
Yeah, T-spine.
Thoracic spine, right? T4, T6 maybe. Good. Pelvis. Anterior, posterior,
Anterior.
neutral. Maybe a little anterior. He's probably still got a little flexion left there, but he's getting his hips flexors starting to get stretched out. So he's got his pelvis more flat on the support surface.
That would be more posterior. If you start to flatten out.
Yeah. So
Posterior, no.
neutral. You want a neutral position when you're laying down. As you get older, maybe you got a big lordosis and you know, and then you got an anterior tilt. So, you know, just, you know, that's what we're keeping an eye on. And then lower extremities, still some flexion going on. Upper extremities.
Just wait there.
Looks like he's weight bearing, yeah.
Yeah, other elbows.
But again, they're still, elbows are still kind of back, so that's not gonna give him as much support as if he, once he gets those elbows out more in line with the shoulder. So they're still behind the shoulder. And how's he help keeping his head up there? Besides the extension,
Kind of resting it from his shoulder.
yeah, he's kind of shrugging his shoulders, keeping everything tight up here so I can control my head better.
Saying that the shoulders are gonna migrate up, their shoulders.
The elbow will, so the elbow's gonna move forward. And maybe a little less activation of the upper traps and stuff once it's up there. So you're still kind of back behind your shoulder. And again, you got that symmetry going on, heads up. Still looking better. So 3 months, we'll talk about it. I'll show you the pictures, then we'll talk about it, and then we'll go to that video. So 3 months. Prone can hold chest and head off the mat for about 10 seconds. So definitely a little better against gravity. Leans on elbows, that helps him. Sitting, able to sit with support, so you're able to place him in sitting and they can sit a little bit, but they still need that support. Facial expressions, body tone, and vocalizations increase. When picked up, brings own body up from compacted. So that first 10 days, first month, 2 months, really want to get those basic needs, right? You're crying to get food. This is more interactive. Getting better against gravity. Now you're able to interact with your environment a little better. Social, begins to recognize different family members, smiles easily and spontaneous. So, you know, a little more life going on there. Crying decreases. Parent mom will recognize crying language, hunger, pain, and tired. So start to recognize what the cry is for. You know, I want to eat. I'm tired. I'm hungry. Reacts different parents present. Tries to attract attention when one is nearby. So socially, you're trying to draw people in, have some interaction. Sensory motor, gradual reflexes disappearing. Hands usually held open, so that thumb is moved out of the palm of my hand, and it's more open now. And usually, follows a slow moving object with eyes and head from one side of the body to the other. So those muscles in their eyes are better now, and they can start tracking objects. And you know, we'll be looking for that when you're examining the baby. May voluntarily hold and wave a toy. Intellectual begins to show memory, explores own face, eyes and mouth with their hands, so they're really starting to touch everything. Again, all those nerve endings on your face and on your hands are self-stimulating. Stop sucking to listen, so they can break out of any activity like that, where before, when they're months old, you know, they latch onto a bottle or whatever, they're just going to keep eating and eating and eating. Now, intellectually, they can stop, like, what was that noise? I want to go look. I want to get away from those primitive needs that I have. And distinguishes speech sound from other sounds. So they're starting to get attuned to speech. 3 months prone and supine. So again, symmetry. Midline control of the head and upper extremities. Balance of flexion and extension. So when I'm able to hold something like that in midline, I got that nice balance between flexion and extension. And symmetry, symmetry, symmetry. I can hold my head in midline, good head controls coming in, chin tuck, writing reaction. Supine, symmetry, a lot of hand and foot play. Explore scissor own body. Repeats activity continually, and you see this a lot with infants. They learn how to do something, they do it, 8 million times. Eye-hand coordination. So again, if I got something in my hand, I got pretty good head control. I can bring it midline, I can look at it. My eyes converge on it, so it's all coming together. And midline control outputs and convergence eyes, which come together for exploration. So pull all those senses together, and really it's got a lot to do with the head control and the symmetry, the ability to move against gravity. Prone, elbows move in line with the shoulder, so again, those elbows are coming out. That's going to move your center of gravity further down your thoracic spine towards your pelvis. Elongation of the hip flexors, this constant kicking activates those hip extensors also. Flattening of the pelvis again, head more stable against gravity. And again, once you have a good head control, I can really start exploring my environment and learning using my eyes. Three-month component. Pelvis moves away from the support surface in supine. Symmetrical kicking, increased lower extremity co-contractions. Again, a lot of proximal stability to do that. If I can get my pelvis up flat on the support surface and I'm kicking my legs back and forth, that's a lot of proximal stability. I'm really pulling in all my lower abdominal. Increased pelvic stability will lead to increased disassociation of the lower extremities. Go from symmetrical movement of bilateral flexion extension to asymmetrical alternate flexion extension. So we got that symmetry. We're kind of moving our arms together, our legs together, same way. And eventually you're going to start to see one extending, one flexion. And that is disassociation. And what's that also going to, what kind of movement is that? Reciprocal, right? So that's all going to lead up to walking, right? If I can use my lower extremities reciprocally. Increased pelvic stability. Again, increases your base of support. And that proximal support is going to let you move distance.
So the asymmetry that you referred to before, like with ACR, that's like different than like now it's becoming more functional, right? Like as they get older, the asymmetry will be more functional versus.
Right. Yeah. So the asymmetry early on is driven by primitive reflexes, and then you just don't have the ability yet to move against gravity. And then, like you said, once you start bringing everything midline, I'm getting good head control, good shoulder control, all this proximal stability, pelvis, then I can start separating. And even my trunk. When they lift their legs up, they're going to rotate their trunk. So you get that disassociation, one body part on the other, and then reciprocal movement. All right, see if I can get the video.
That's a big smile. There's lots of social presence. Looking. Yes. Looking.
So you know it's right. He's looking, but his head's in midline as opposed to the newborn before.
All those bright lights.
And look at his hand, right? It's not kind of like this anymore. It's not tight-fisted. It's open. And he's really focusing on the clinician.
Aware of his environment, just looking around, taking things in. Okay.
Stimulate him.
Just look right over. How about looking in? What's it? Kind of a frown. I don't know quite to do with this, huh? Yeah, yeah. Oh, you can smile for me? Can smile for me? Yeah, that's a big smile. Very good. We're just going to do doll size. See how we can go back and forth here.
So everybody sees that, right? So he's turning his head, but where's his gaze going? He wants to stay on the clinician, so his eyes are going back and forth. He calls them doll's eyes, which is... Years ago, they used to have dolls in your eyes.
Introversion, 80 degrees. And then we're going to do vertical. Okay. What to do with this, huh? Yeah, yeah. Oh, you can smile for me? Can smile for me? Yeah, that's a big smile. Very good. Yeah. Okay.
So, you know, our social interaction, talking to him, and the hand in the mouth constantly self-stimulating.
Is that a normal, like, shape for a baby's head? Looks like really long.
Yeah. Yeah, that looks about right. But again, they used to have forceps, now they have these little, like a vacuum suction that would pull the kid out. Maybe that happens. I mean, he's pretty good.
Should we pull you up to C position? Okay. Now we're just going to do passive range of motion.
So again, it's symmetry, right? His legs kind of doing the same thing, arms are doing the same thing, and his head's in midline. And he's, you know, looking at the clinician.
Chin. Child's good. Can go to the shoulder but not beyond. That's good. Traction, remember, we can hold on to that. There's resistance.
And the whole time just focusing on the person that's moving around. He's not getting as upset as the infant does from all that movement, because it's not as scary for him.
You can see that his hands are more open and closed, and not being held closed like in the newborn period. And oftentimes they'll be bringing their hands so to start looking at them. And if we put an object in his hand, let's see if you can hold on to it. Don't take it, but if we hold it, put it in, grasp it, hold on to it. Okay, that's good. Let's try this side. Okay. Yes. What is that?
So you can see he's got something in his hand, the bell, it's making noise, feeling in his hand, but where's his attention?
Still on that.
Yeah, it's still on. You know, so the hand is still on, not a lot of eye-hand stuff yet.
So it goes onto the object. Well, it doesn't actually reach and grab the object. It's replaced in his hand. We'll place his hand and hold on to it. Okay, very good.
Ever got something on a pen, whatever, just put it on the table, reach for it, grab it, and then put it somewhere else. Anything, okay. So in order to do that activity, what you have to do?
What's that?
You gotta look at it,
Yes.
you gotta reach for it, grasp it, right? Move it somewhere else, and then what?
See where we're going.
Release. Right. So and then we'll talk about that, and then everything that's involved in that. You have the good shoulder, good hand-eye coordination, depth perception, okay? Everything that you take for granted. So, and then children with problems are going to have difficulty with that, or somebody with a stroke. Yes.
It's really interesting that you say that. I worked with a therapist who had a patient who was able to pick up an object, but she literally could not, like, let it go.
Sure.
She did not know the concept of, like, letting it go. She would literally put it on the table and then let it go. She didn't, like, understand the whole drop concept.
And see that with, and the other thing is isolated movements. I can bend my elbow and lift my shoulder. Again, people with strokes, or even children that have less spasticity, you're going to do this whole body movement. Try and pick something up. A lot of times you do what we call pronator drift, where you pronate the arm, and you try and pick stuff up like this. But my whole body moves together. I don't have any disassociation where I can flex or supinate my arm. And that's kind of what the baby does when he's holding. It's kind of immature type of grasp in upper extremity power.
The lower extremities now, just a range of motion at the hips. Good resistance, but not too tight. Again, looking at holding one side and flexing the hip at the other side.
And you remember the other baby, all that flexion, brought him up, he could only get like 90 degrees of knee flexion, and then you saw his hamstrings are lengthening out and get better.
Look at the knee and hold that up. It's more good resistance, but not too much. Look at the ankle. Do you not have any ankle fullness? That's fine. Okay.
Again, spontaneous move at the upper extremities, he's reaching for things, and again, he's got that better head control. He's able to look at the clinician and hold his head with his chin tucked.
Now what we're going to do is we're just going to come to sitting, get some headlight there. I should be able to bring his head up. And just see, it's still rounded in his back. Okay. Still kind of wobbly, but I can hold it there. That's good.
So, you see all that suboccipital extension there where he's holding it back. That's how he's helping to hold his head up. But, if you remember that other child, he's able to hold his head up for quite a while. Again, you get him some support. And, like you said, posterior pelvic tilt, rounded shoulders, spine out, and he's coming out of ligaments there. But definitely better control than the one before.
And that one before is kind of sitting on the sacrum, right?
Yes, yeah, back on his sacrum. Eventually it's on your ischial tuberosities. Anybody notice anything there?
18R looks like.
Yeah, right. So we've got to say turn, focusing on the clinician, and then we've got the skull side extension and face side flexion, but not so much in the lower. Again, child with a problem, going to be locked into that pretty good, and you're going to see more lower extremity flexion on the skull side. And you just have a general increase in tone. Once he turns his head, he doesn't control himself that well. He's going to kind of hold on with everything, so you get a little more increase in tone. But again, a lot of spontaneous movement, and you see it's symmetrical, right? Lower extremities are flexing and extending. Same thing.
Oh, yes, yes. Okay.
So again, asymmetrical with the head, but he's turning his head, and you see that arm come straight out every time he does it. So a real good extension there. He's kind of flopping all over the place. But what he's working on is getting his arms out from underneath.
All right. So we bring your arms out here, gets his head up.
See, as soon as he brought that elbow forward for him, he's able to bear some weight and get his head up even better.
On his forearms and looking up.
And that's a real nice position. See his elbows are out in front of him. He's he's starting to open his hand. And all this again is support surface here, a nice tripod going on here. So he's got a lot of support, and then he's able to hold his head up against gravity better.
Yeah, that's pretty good. Yes. He's in there high enough that he'll be able to roll over here. Okay. You can do it.
Just about getting ready to roll.
Just about made it. Yeah. Okay.
But you hear him, he's working hard. Not, probably gonna start crying in a couple minutes if he stays like that. But you can see this general increase in tone, extension tone throughout, until he learns how to control it better. But right now, he's just got a lot of extension. He's just trying to make himself real stable to keep his head up. So he's just letting everything go.
Very good. His head's up, his chest is off the mat. He's got his arms here, and that would be a good position for maybe his age. And there he goes. He's rolled over.
That was a nice transition.
Again, he gets his head up, and he's maintaining it above the plane of his body.
So he's stimulating him there. He's got his extension there pretty well under control. The other baby, remember, as soon as he touched him, he kind of started to extend there. And what else do you see there? What's helping him? What primitive reflex is helping him with all this? So he's definitely writing. So that's not primitive though, right? So that's a postural reflex. What's a primitive one? What's his head doing? What position? Extension. What's his arms doing? Extension. What's his legs doing?
Extension.
More
Yeah,
flexion, flexion, right?
Yeah.
Which one's that? Do you remember? His head's in midline, right? So it's what? Symmetrical? Estino, right? So as opposed to asymmetrical, now I got symmetrical. Now he can do a lot of this himself, the writing the action, but it's definitely there, and it's assisting his movement against gravity. Everybody see it, right?
It would also be STNR if his head was flexed and his arms are flexed, but his legs are extended.
Correct. Yep. But here, this is a good sign because he's there and he wants to right his head. So everything's kind of working together. Got a postural reflex, primitive reflex, but a lot of this is himself controlling it because he wants to lift his head up. It's not good that he does. So that's nice.
Body. So we get his legs up too.
And he breaks out of it, right?
So he's opposing gravity at this point in time. It's like he's going to be in a control position. So that's good.
So a child with a problem, they might be stuck like that. He can move in and out of it. You saw his arms move from flexion to extension. Same thing with the leg.
This is all part of like an assessment you would do,
Yeah.
evaluation.
Put him into vertical suspension. And let's see if it can support weight on his feet.
And if you have a good pediatrician, a lot of times they'll do a lot of this in the office.
He's got support weight on his feet, so he's got a positive support reflex at this point in time.
So again, pushing down into the support surface with his legs. That's not falling into gravity. He's pushing down. He wants to extend his legs.
Yeah, that's good. It doesn't slip through my hand, so he's got good shoulder girdle strength.
And that's the other thing up here. He's not holding them like this, right? He's able to push down, hold pretty tight, and with his upper extremity and shoulder.
We're just going to test reflexes at this point in time, and we'll start here at the lower extremities. And just relax, rest, and normal. You get a little bit of cross adductor, which is this other side coming in and being abducted. And that can be normal at his age.
See, what's that one?
He's doing like a brisk dorsiflexion, almost like a Babinski.
It's cooing, and that's good. Okay. Just try over here. And here's normal. Your triceps. In this age, we can really get triceps. And so you relax enough to do that. Okay. Going to turn. Then let's to the side. See the as Babinski, and that's where you would expect.
Everybody-
Going to turn the bend of the toes.
Everybody seen a Babinski
Yes,
before?
at this age.
Heard
Okay.
about it? So your toes kind of fan out, especially the big toe.
Yes, okay.
Not as strong, right? And in fact, he was, talking to the clinician or whatever, so he was looking at the clinician. Before, the other baby turned and he was really, looking for something. Rudy, he stimulated the side of his cheek.
Yes. Yes, okay.
It's not as strong anymore.
We're going to look for a role. At this age, he may get fussy at this, but okay. Those lashes were on at this point.
So again, it's decreased a lot, right? Remember the other kid, his arms were shot out and it came back like this? Where this is, a little bit, but not exaggerated. So a child with a problem, if you did that, they might hang out there and then come back slowly. It might be more exaggerated.
Time. It's usually this time they do lose some room. So he doesn't have room, so that's good. Let's just look at the galant reflex, which is the incurvation reflex, and just stroking the back. He still has a galant. So he still has some of his primitive reflexes. The incurvation is going towards the stimulus. Okay.
So that one's still there. He's stimulating the side and he's lateral flexing to the side of stimulus. That hangs on pretty long time.
As far as the grass reflex, still has some grass reflex there. Grass reflex there. And then let's take a look at his feet. Okay.
Let me see his toes growing, right?
Put his head in midline. Okay. On both sides. He wants to turn over this way. Put him this way. And we get into somewhat of an asymmetric type neck. You can see this hand extended and this leg extended and the other side flexed. But he can overcome that. He's not obligated. Go this way, and turn it this way, and again we should see, I like that, this head extend and this foot extend, and this side flex over here. Okay, that's an asymmetric type neck. Coming back over here again. Oftentimes you'll see the side where the head is turned towards an extension as far as the leg and the hand, and the other side of flexion, but he doesn't get stuck in that. And he shouldn't be, so he won't get out of that.
Again, he's moving ahead. He's not getting stuck in it. Child with a problem, turn his head, he'd be kind of locked into this position of flexion on one side, extension on the face side. Okay, so he can move in and out of it, which is great. It's not controlled by his primitive reflexes. They're not pathological.
At what age are the primitive reflexes pretty much done?
Yeah, so it's probably around, some of them go up to 2 years, but around 8 months. You know, once you're pretty good against gravity, you're kind of not around too much anymore. But even when you yawn, you know, a lot of people, it's like, you'll see you go into that, you know,
Yeah.
flexion on one side. Now, one handout that I like to have the bars, you know, the very last one for the reflexes, it's got a timeline, and I'll have like, 2 to 6 months for whatever. So that's a nice one to look at. But most of them are gone. Once you're against gravity pretty good, you don't really need that extra tone or extra increase in muscle tone to help make it more stable.
What about when like you swaddle a baby and then they like when they're unswaddled they like throw their hands up? Is that like
So there might be a little more left. We're talking about when you're,
like I don't know if you've ever seen those videos of like a baby swaddled and then when the mom takes it off, their hands like
yeah,
shoot in the air or they're doing that stretch.
yeah, so it's probably more moral.
Okay.
Maybe they let go and it just it's all flexed up so you move. And any sudden jerk a lot of times with a baby, yeah, you're going to see that moral reflex, especially if it's with the head.
Was there a link to that website anywhere in the?
Yeah, I'll try and remember to send it to you. I'll send the PowerPoint. Yeah, it's just, unfortunately, they don't, I've got some pictures of kids with CP and spina bifida and other things, but they don't really, it would be nice if they took maybe a kid with cerebral palsy and did him at, those different ages too. So all we really have is that newborn in this video to look at, compare, to abnormal and normal. But you'll see it, if you know normal well, you're going to kind of know abnormal when you see it. Okay, 4 months. Supine, moves hands to knees, may lift lower extremities up in the air. So you're really getting pretty good against gravity. Prone, practices bilateral use of flexion and extension, so symmetrical frog, like a frog leg. Swimming motions, arms away from the trunk. So I got everything up away from the support surface. I'm able to move my arms and legs. Total extension. And move arms away from the trunk, elbows in front of the shoulders, so they're further out. May roll accidentally, and maybe even earlier than that. The child was 3 months old and rolled. And equilibrium response, developing prone. What do you think is going to be harder, rolling from prone or rolling from supine?
Supine?
Supine, right? So you got a little bigger fight against gravity there, right? Although some kids roll from supine to prone first. That's the rolling is, everybody does a little different. Again, motor may roll over and turn head in all directions when in supported sitting or lying down. So got good head control against gravity, but in supported sitting, you still have to have that proximal control. Social, laughs while socializing. Cries if play is disrupted. Interested in, may smile at a mirror image. Attempts to soothe self, so they're really learning how to calm themselves down again, self-regulating. Vocalizes to initiate socialization. Laughs and tickles. Adjusts response to people, provided by music. And may interrupt feeding with play. So again, becoming much more social, can move away from their basic needs and wants and concentrate on higher development socially and intellectually. Sensory motor, may be ready to start solid food, although most of them recommend around 6 months. Pulls dangling object toward itself and carries it to the mouth. So that's that first reach, grab, translate it, and put it somewhere. So good eye-hand coordinating. You also have to have depth perception, okay? You have to know where that thing is in space. Stairs at place from which an object has dropped. So again, that's that object permanence. So I get hold of something in my hand, I might drop it, it's gone, but I'm kind of saying where to go. You know, I saw it in your hand, now it's not there. Splashes and takes a bath. Displays interest in and can distinguish smells. May hold object between index and second finger. And we'll do a lecture on hand development too. There's a certain way that grasp develops with the hand. Intellectual. Has responsive periods for more than an hour. His memory can span 5 to 7 seconds. Smiles and vocalizes more at an actual face than at an image. So, really interacting with humans. He's interested in making new sounds and imitates several tones. Good head control with pull to sit. So, good writing reaction, good chin click. Good line. Open. Documents going, open. So a lot more going on in 4 months. So this picture, where we see, starting at the head.
Oh, we're looking at the top left?
Yeah, where the mouse is, I'm sorry. This one.
Alright.
So what position is it in?
Sports center.
Yeah,
No, these pictures.
the top left. So kind of in a chin tuck.
Right.
Looking at
Midline, chin tuck, good, yep. Trunk, not too much going on, right?
Yeah.
Pelvis,
A little more neutral, I
Neutral,
guess,
got a little-
because the legs are
yeah,
flexed up, so.
yep. Just like you, if you laid on a bed and you put your knees up, kind of flattens your spine out right away, right? And then the extremities,
Be able to come towards the mouth, hands towards the mouth, I guess.
what position are they in? Flexion and the bolt inflection?
Yeah, symmetrical.
So it's symmetrical, right. So the upper extremity, lower extremity, flexion, symmetrical, and then got something in the hands, midline holding it, and they're in the mouth. So hand-eye coordination. So this picture, starting at the head,
Extended back,
extended, trying to do a what?
for writing.
Writing reaction? Yep. Kind of hold the head up, with the eyes up. Trunk,
I mean, it looks extended there.
right, so you got, yep, down thoracic spine, moving down. Pelvis, anterior pelvic tilt, still, that's because of the hip flexion, right? So you still got some hip flexion going on. And then the extremities, symmetrical again, right?
Being held here, right? It's being held. Is this being held?
No, he's on the support.
He's on the
system.
floor.
Yeah. So symmetrical again, right? Extended, flexed. And then what are we going to talk about with the, when you're in prone? What's the relationship are we looking at for the upper extremities? A couple things, right?
Weight bearing, yeah, elbows. And
Shoulder and elbow,
girdle.
right? So it's moved out, right? It's not back here anymore, the elbow. Now it's moving out.
Okay.
It's going to give you better support. It's going to give you a bigger base of support. It's going to help you with your head control. And then the hand. The more I start pressing on the support surface, I'm gonna open my hand up. You know, just like you, if you kept your hand fisted and you're pressing down on your hand, you're gonna want it to open up after a while. So that stimulus of weight bearing helps you open up the hand. And that's gonna get the thumb out of the palm.
When you say symmetrical, I'm just a little confused. Is it like both are in flexion, both are in extension?
Yes.
Or is it like one is in flexion, one is in extension?
So the extremities are doing the same thing. Not same motion. Lower extremities are both extended, upper extremities are both flexed.
Okay.
And then you're gonna start to see, the next picture, you're gonna start to see some asymmetry, because you want that, because that's gonna move to reciprocal motion.
But then it's not saying like the upper and lower extremities are symmetrical to each other, it's the upper extremities symmetrical to each other and the lower is symmetrical.
Right. It could be both extended, one could be extended, one could be flexed. But, you know, that symmetrical posture that you see at times. It's not to say, you know, they're like this for all the time. They're moving in and out of it, but it's more, symmetry dominates a little bit more. And here, so he's shifting his weight over to his right. Again, he got good head, righting reaction, extension in the trunk. So he's activating those glutes, so that's going to help him extend his hip. That's going to help him stretch out his pelvis even more, stretch out those hip flexors. And this one, got a weight shift going on the elbow. But again, those elbows are out further from his shoulder now. And what's going on? What position is the baby in this one?
Sideline.
It's sideline, right? So that takes a lot. Really working on your equilibrium there. Working on your head control. And how's he helping him support himself? How's he helping him keep his balance?
His left hand
Yeah, it's like separated.
and his left foot caught in front.
What was that
His
over there?
legs are separated.
Yeah, so he's making a nice wide base of support with his legs, right? So it's helping him keep stable. But sideline, and then his pelvis is a little rotated there, so you're starting to get some disassociation. Trunk on pelvis, some rotation there. And again, sideline position. Right there and here. Look how, you know, his arms are really out in front of him. His eyes focusing on whatever his hands are doing. And weight bearing on that elongated side. Okay, pretty good shoulder control. It's not just slipping it into the arms. Got some pretty good shoulder control. It's not holding the baby like this anymore. They're able to put their shoulders down. Got some pretty good upper body control. And then extend it into gravity. Pushing those legs down in extension into the support surface. Five months. Pull to sit. So head's maintain a good alignment. Good chin tuck. Prone, equilibrium response present. Increased lateral weight shift. Plays on extended arms. And you know, I can pick one. I can shift my weight laterally, so I can hold something or move it. Pattern of elongation again on the weight bearing side. Pelvis is definitely flatter and prone. And weight shift. We're going to have weight bearing, cephalocaudal, and proximal distal. And again, starting to get disassociation of those lower extremities. Supine, neck elongation. So if I'm getting neck elongation, what's happening?
You're right. Yeah.
Right. Chin tuck, right. So I'm definitely trying to right my head. I'm getting a chin tuck, and I'm getting better head control. Controlled elevation of the pelvic, hands to feet, so I'm able to reach down, grab my feet, play with them. So I'm really controlling my pelvis. So I'm getting in a posterior pelvic floor. Shoulders are stable, can move arms away from the support surface. So I can put one arm down, hold myself, and move the other arm around. Motor may locomote by rocking, rolling, twisting on the back, kicking against the flat surface. So I when we see a video, you'll see. But I'm just trying to find any way I can to move. I'm not crawling yet, I'm not doing commando crawl yet. I might be, if I'm supine, pushing in the support surface to help myself roll over. Intellectual. Utters vowel sounds and a few consonants. P, D, I, N. Say those letters. What do you notice about your lips? And your tongue.
Moves smooth with the tongue, doesn't it?
So with a D,
It goes on the
where's your tongue?
Roof?
Roof of your mouth. Okay. And where's a B? What are your, D, you can do it with your mouth open, right? Can you do a B with your mouth open? You have to close, you have to get lip closure. So this will have to do a lot with speech and development. But same thing. Those first sounds are more duh, duh. There's not a lot of So I'm not, that lip closure, that's important. That's part of development. A lot of the first sounds, you're using your tongue in the back, the roof of your mouth, to make noises. And lip closure is very important.
So they say dad first, right?
That's because it's easier. That's yeah. You stole my thunder. I always like to bring that up. So what's the first thing they say? Dad, 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 right? Because that's at the roof of your mouth. Mom, you have to close your lips. Discriminates self from others in the mirror. Looks around in new situations. And again, wants to touch, hold, turn, shake, and mouth objects. So you really want to put everything in your mouth, but really getting interested in your environment, and you're getting that, yeah, I can't believe you can do that. And squeal, blow raspberries, and then it imitate sounds and movements. So intellectually, they're imitating things. But again, you're starting to get that lip closure. Kids with problems often don't get that. 5 months, and 16, okay. I think the next one is 6 months on the video. So end it here, and see you Wednesday. So I'll get the video link out to everybody, and I think I'll switch to, no, we'll do 6 months, and then I'll give a fine motor lecture, because everything kind of happens at the same time. And once you're sitting, what does that mean? If I'm sitting, if I'm able to sit, what's going on with the child?
Good core stability.
Right. So you can support good core. So what does that mean? Good what? Good proximal stability. So if I'm good proximally, what's that going to help develop?
Start building.
Distal, right? So once you're around 5, 6, 7 months, you really got some. You're able to sit. Once you can sit, you can start using your hands better. So you get more eye-hand coordination, and then we'll talk about how fine motor develops. Okay. Any questions?
Just, I kind of wasn't really understanding why DBIN, but why they can make certain sounds at this age and not others. You're
Yeah.
saying lip closure, and
Lip closure is the biggest one.
what does that mean? Like,
So say M. What happened?
close my mouth.
Had to close your mouth. So you got lip closure. If you say D, did you have to close your mouth? No. So typically those sounds are a little easier to make early on because I don't have to close my lips. That's when they're blowing raspberries, stuff like that. It's pretty high level because they can close their lips and make noise with them. So that lip closure is important, and that's happening around this age. Okay? Answer a question or no?
Again, D you don't have to, so then why are they together? You know what I mean? Like D you don't have to, but M you do. Right?
Yes. So maybe I shouldn't put them together. Is that what you're saying? So D those tongue sounds on your roof of your mouth, they come first.
Okay.
And then once you master them, you'll start to move forward with your mouth
But
and
it's
start
kind of all
closing
around
lips.
the same age, it's just,
Yeah. This is once you're getting pretty good against gravity, got good head control, you can start making some of these noises.
talking the M is gonna come a few weeks after the D, maybe.
Yeah, it might even happen at the same time. Some kids are pretty good, but typically that's how it is. It's easier to do that that noise in the back of your throat, to the roof of your mouth with your tongue, then is to close your lips. The point here being lip closure. Some of those kids never develop that. Good. All right?
So we can do. Every single one of my Instagram posts.
So HD and R, asymmetrical, right for asymmetrical.
No, we didn't get it.
You didn't get it?
No. Unfortunately, I wish.
Me too. We had,
Do me a favor. Oh, my phone. I don't usually have my phone, but let me call. Hello, Devin. Leave him alone.
Say what's up. Hey man. What's going on, guys? I miss my buddy.
Can we just talk about how the past 2 weeks drove right into the lab to tell our professor that we're the troublemakers? This kid was sliding all over the table. So I have to hang on to it every second. Flying around our lecture hall and then hang out. Kyle and I sitting here. Yeah, I don't know why they would do that. And I don't even know if that's going to do him. So, yeah. Did he look good? Did that look good?
That's one.
Yeah, what was your tuition for this semester? Yeah.
I'll have to look, because I took that history class over winter break, so it was drafted into that, so let me look at it when I go home.
Yeah.
And I'll text it to you.
And just minimize, or just like minus the history classes, you can figure
Yeah,
that
it
out.
didn't go out.
Yeah. That will happen. Yeah, so I'm still behind. Because they charge me at 3,300. Look at all this caffeine I'm slugging over here. I'm talking about their honestly, you need to get me there's no one up in Berkeley right now. So that's yeah, I may as well. No, there is. I mean, it's a person.
You guys have some other schools.
So I may as well just utilize my time here instead of trying to call me.
Yeah,
You only know it's so hot, so double check that.
let me see if I can
Implanted in his forehead, like. She said 3,000. Yo, if I see see that dude in the street, you better believe.
No, that's,
Shit,
that was
taken
taken
that
out
out of his fortune.
way illegal.
Did you guys get it?
Seriously, got a $24 million gigantic ink diamond imprinted in his forehead, and he expects
Did you get the email, guys?
ripped up.
It just came through,
It
yeah.
just came?
Yeah.
Okay.
Is Monica on the screen? I'll send her a text. Should I send her the link?
Monica? Neil's here. Monica's not here.
Alright, what's with
Monica?
all these people not showing up, man? I live on top of Mount Randolph. I got dogs about this shit, you know what I did?
All right.
Dusted my Jeep off and I got
Okay. All right. What'd you get to in lab?
We did wrapping of the stumps.
Did you do stump wrapping?
Yeah, we did the gloves, we did the gowns.
Did you do AK and BK?
Yeah, we did transfeminine.
Everybody did it?
No, we just did, our section only did the BK.
Okay.
We did.
Because it's really important when you do stump wrapping, especially when you do stump wrapping for an AK or transfemoral amputation, that you encourage extension. Okay, so we'll go over that again today. Did you do tilt table?
No.
Okay, what's the thing you have to worry about when you get somebody on a tilt table?
Orthostatic.
What is it?
Blood pressure.
Orthostatic hypotension. What is orthostatic hypotension?
Low blood pressure from changing position. From supine to
What's
sitting
it?
up.
How do you determine somebody's just not a little dizzy as opposed to having truly have an episode of orthostatic hypotension?
20 millimeter change in the system.
Yeah, a drop of 20 millimeters or greater in the systolic, yes. What do you do if somebody's in an emergency situation? I got it, thank you. All right, bye. Sorry, just, if someone is someone is undergoing orthostatic hypertension and they're on a tilt table, what do you do with it?
Bring it back down.
You lower it all the way. What would you do if somebody has autonomic dysreflexia and they're on the tilt table and they feel dizzy?
Just sit up.
Keep them semi-recumbent or sitting up, right? What do you do if you're wheeling somebody in a wheelchair and they have orthostatic hypotension?
Tilt.
Yeah. You put your foot on the back of the wheelchair, there's this little extensions, and you pull the patient back, okay? It is not uncommon for a patient that has orthostatic hypotension to start to vomit on you, because they start to feel cold, clammy, they start to feel sick. They said they feel sick to their stomach, and it's not uncommon. So know that. And especially know that if you're walking with somebody and you have somebody on the stairs or something. You know, you generally, when you do stairs with a patient, we're going to talk about elevations as far as level surfaces and ambulation. You're not going to take a patient just to the regular stairs in the facility. You're going to take them to a set of stairs or a flight of stairs, especially if they have those at home. So know that, because you're going to be at the top of the stair, and if you're by yourself, you're stuck because you're going to be in the stairway, okay? So know if somebody's got orthostatic hypotension. How do we prevent it? How do we prevent it? Got a patient has orthostatic hypertension, what do you do? We're gonna acclimate them or get them up gradually, but the other thing we can do is we can do wrapping of the distal lower extremities, right? Do ankle pumps, anything to encourage venous return. Because remember, we have a decreased CO2 from the periphery to the heart, a decrease overall cardiac output, decrease in cerebral confusion, somebody faints. Okay? As opposed to autonomic dysreflexia, which is if somebody's got this massive sympathetic response going on because they have nothing that's traveling up and down. We haven't talked about all these tracts, but there's a lot of tracts that you'll have to know. We mentioned the spinal thalamic tract, lateral spinal thalamic tract. Did we mention the No, I think that's the only one we mentioned. Spinal thalamic tract, which is responsible for pain and temperature. We didn't talk about dorsal columns, which are responsible for proprioception. These are sensory tracts. There's also motor tracts. Okay? So, sensory and motor. That we'll have to think about, and there's nothing going up, there's nothing coming back down. It can't, because you've got a complete severance of the spinal cord. Right? Complete severance of the spinal cord. Jasmine, you said you were going to be out? No, that's not Jasmine. Jasmine was out, okay. Okay, so when we talk about equipment and we talk about catheters, what is a catheter? Catheter is just this rubber or this plastic or this metal tube that's used to provide medication or to take out fluid or to feed someone. So we use catheters, we use nasal catheters to provide oxygen. A urinary catheter is to provide a method for their urethra to drain, so something to drain from the bladder itself. Suction just means that you're going to remove some secretion, so that's just the definition of suctions. And an NG tube removes fluid or gas from the stomach or the GI tract. We would also use it to provide medication, so we could do parenteral feedings. With these type of tubes, the patient can't eat or drink on their own. You can exercise the patient, but when you're exercising the patient, just be careful not to dislodge the catheter. And a gastric tube is inserted into the stomach. So that's a medical procedure. They have to do an incision and insert the G tube right into the stomach. If they can't do an NG tube, they do a G tube. Urinary, I meant to take this out. External condom for males. The condom catheter is for males only. But there are other external catheters now, and I'll show you a picture of it. There never used to be, but now there just used to be an external catheter for a male and an indwelling catheter for both a female and a male. Okay, so there's a condom catheter, and that's what it looks like. It looks like a condom, and it has a tube attached to it, and it drains into a collection bag. Okay, what's the problem with these? They fall off, right? So they have to be taped on, and they fall off, and if someone has it for a long time or needs it because of paralysis or something, they would do something more like an indwelling catheter. Well, when you do an indwelling catheter, what do you worry about? What do you do when you put a foreign object inside? You worry about sepsis, right? So if you do an indwelling catheter, you worry about the fact that there can be an infection. You've heard the terms UTI, urinary tract infection, right? So you can get a UTI with a catheter. So an indwelling catheter goes from the urethra directly into the bladder. There's a balloon. There's usually 2 or 3 tubes. There's a tube to drain the urine, and there's a tube to irrigate the bladder. And they put this tube in, and they have this balloon. They inflate it with sterile water, and it has a little balloon that's formed so it's not easily dislodged. Okay, I'll show you pictures of it. Suprapubic catheters is, again, surgically inserted directly into the bladder through the lower abdomen and the bladder. And any catheter is used when voluntary micturition means voiding, urinating, okay? Voluntary micturition is lost. So, should we put an indwelling catheter in our 70, 80, 90-year-old women and men that are in subacute facilities? Should we do it? Because they drink a lot, or older men, maybe some of you are not old enough now, to have little prostate problems. I'm sure some of your parents do, some people you know do, right? So should you put an indwelling catheter in them? No. You should only use an indwelling catheter if someone truly has lost or is incontinent. I mean incontinent because of they've truly lost the sphincter nothing, they can't void, or they void all the time, or they don't even know when they're voiding, or paralysis or something like that, okay? Because there's a lot of side effects with this, and one of them is sepsis. You know, you could die from sepsis. Sepsis is a systemic infection, okay? So if you don't need a catheter, don't put one in. They can be temporary, they can be permanent. Problems though, complications, UTI, urinary tract infection, a urethra fistula. Anybody know what that is? That's a hole in the urethra. Bladder calculi, you know what stones are? You ever pass a bladder stone? Very, very painful. Kidney failure, and also can be that patient that's that T6 para and above, autonomic dysreflexia. So what do you have to look at when that person comes down with that indwelling urinary catheter? What do you have to look at? What do you think? They come down, they're brought to your floor, you're thinking you're going to put them on a tilt table, you're going to look at their vitals, you're going to try to stand them up just so that you can drain the urethra and prevent pneumonia and help with the bone loss, et cetera, et cetera. What do you think you're going to worry about? What do you think you're going to look at? They come down with this catheter.
Maybe that it's not like kinked or turned or fell
Not
out.
if it's kinked or turned, what else? What's a real, what do you think? You know what a urinary catheter is, right? And I'll show you a picture. The catheter is in the urethra. The backflow, yeah. So you want to make sure that bag is not full, okay? If it's full, it should be emptied, all right? Because you're going to get a backflow of urine. It's not something that you want. Okay. Be careful not to dislodge. So, you've got a patient that has a collection bag, they have a urinary catheter, and you get them out of bed. Where do you think you want to hold the collection bag up like this when you're walking with them, like it's a little, no?
No.
So where do you think it should be?
Oh,
Below the level of their waist, right? Because you want the urine to drain. So if you have a walker, it can be at the bottom leg of the walker, or you could hold it down as you're walking, all right? Because you're going to have to hold it for the patient. You are. So what are you going to put on?
gloves?
Yeah. Are you going to put on a sterile or a non-sterile glove?
No.
Yeah. You're going to put on a non-sterile glove, and you're going to walk with the patient. And it's going to be below the level of the waist. It's going to happen. I mean, and it's going to be, you know, if you think that bothers you, it bothers them a whole lot more. It does. Because nobody wants to be in that situation, right? So don't dislodge it, meaning be aware of your surroundings. We say that all the time, right? So, I've seen it happen more times than I'd like, that you're walking with a patient and you step on it. And what happens?
Pushes it.
It pulls out, it goes all over the floor. How do you think that feels? Imagine in your penis or in your urethras, in your vaginas, well, through your bladder, a plastic thing that's inflated with a little balloon that holds it in place and then it pulls out. It is not comfortable.
It's like the movie Swimmer.
Okay, so not only is it embarrassing, it's painful, and then you have a mess all over the floor. Okay, so be careful when you work with a patient. Make sure you notice they have a catheter. Make sure you look, because you're going to be working with an IV pole, a catheter, maybe some other kind of lines that they have. You don't know. So you're going to have to look around you and see everything that you need to collect and do before you even get this patient out of bed.
Will it be, will that all be on like their chart and their?
Will it be on their chart?
Yeah, like, because I don't even really know how a hospital works, like when you go in for that patient.
No, Well,
This would all just be.
it'll say, it'll probably say in the nursing, things that they changed, that, they changed the urine, patient has a catheter, in the nursing notes, it'll probably say that, yeah. But, you walk in a room and you don't think that, sometimes you don't even think to look at that closely at those notes. You walk in, first thing you wanna see is you wanna see that you wanna see that urinary bag, that collection bag. Because that's the worst thing to do is step on it. If you have stepped on it, what do? Put it back, right? No. No. This person has to go back up to nursing, right? It has to be clean, it has to be sterile, they have to put it back in, they have to get a new one, yes.
Are they typically inserted under anesthesia?
No,
No?
no. It just insert.
Go for it.
That's what nurses do. So, all right, so be careful, be careful. So don't try to reinsert it. Position bag below the bladder, we already said that. When you're in water, you guys know this, right? You feel the hydrostatic pressure against your limbs. That's what, and buoyancy and everything else is what keeps you up. We haven't really talked about the principles of water. But one of the things that happens when you go in water, or when somebody runs water, what do you have to do? You feel like you have to pee, right? You ever jump into a pool and, you're in the pool a little while and you're in the deep end or something, and you feel like you have to go to the bathroom. Right? So these are due to hydrostatic pressure. So if you're putting somebody in a whirlpool, make sure that the bag is void before you put them in the whirlpool. Okay? Make sure it's empty. And there's many times when the nurse is making documentation as far as how much is collected. Okay? So you can call up and you could say to the nurse, he's got a full bag and I'd like to empty it. Can I do that? Sometimes they may say, I'm going to come down and do it myself so they can look at how many cc's. But if it's a full bag, usually it'll tell you how much the bag holds, and you say the bag is full, and they'll say okay. They'll just ask you to note the color, the smell, if it's clear, if it's dark, if it's yellow, if it's red, indicating maybe somebody has decreased fluid intake or too much fluid, or they have blood in the urine, so hematuria. Is it cloudy? Is it dark? Okay. These are the external female catheters right now. This one is the name of it, PureWick, but there's a few out on the market. But the PureWick, you have to have a suction, hospital wall vac suction. So you can't really have these at home unless you have the ability to have suction. So it's a catheter, it wicks urine away from the patient and it puts it into the designated catheter, and this catheter goes into this container. Okay, so that's what, I was going to show you a whole video on this, but I don't know how old you guys are. No. No, it's this, you may see this in the hospitals. Okay? Because when you think about it, if someone is incontinent and you have to do an indwelling catheter, as I said before, you have to worry about sepsis and all the other stuff that's associated, other complications. So someone came up with this great idea for this suctional device, and it stays in place as long as the suction is on. Okay? It's not as easy as a condom catheter, because a condom catheter you can go anywhere you want. This patient would have to stay close to where the suction device is. Okay? But it makes the argument for not sticking something into the urethra. Okay? So you may see this. So condom catheter, if you see a condom catheter, and what do they do with this catheter, with this collection bag? Sometimes they attach it to their thigh. Okay? So if it's attached to the thigh, and this person is coming down to see you, and again, you're worried about autonomic dysreflexia, what can happen? The attachment can be too tight. All right? So you have to check everything. You have to see, did they is the catheter bag, or is the collection bag tightly held to the leg? And is that what's causing, remember I said, what happens with autonomic dysreflexia? You have to find what the noxious, everybody knows what noxious is, right? Noxious is painful. You have to know what the noxious stimuli that's causing the problem. Okay? Emergency situation, because number one, you worry about what? The blood pressure. Number two, you just try to find out what the noxious stimuli is and remove it. And this is a Foley catheter, so that's an indwelling catheter. So you can see the collection bag is still here, but it's in the urethra. That's the little balloon that they fill with saline so that it doesn't fall out. It's inserted into the urethra. And here, indwelling female and male catheter. Okay? Suprapubic, they have to, this is a surgical insert, they insert it surgically with a fuse. Okay. So what is incontinence? Incontinence is inability to hold your bowel or bladder, right? So if somebody's incontinent, and you see this a lot done in rehabilitation places. They want to establish a routine for a patient who may not want to use a catheter. Okay, they may want to use a catheter sometimes, but you know, when you think about your ADLs, some of these people, some of these kids, some of these children, they're 20 years old, 15 years old. 15 years old and have a severe accident, you know, a motorcycle accident. They fall out of a tree. They dive into a shallow pool. You know, all of these things can cause you to become paralyzed, and you're young. So maybe you don't want to have a catheter on all the time, a urinary catheter. So you can establish a routine. It takes time, but you establish a routine. You have to have your fluids at a certain time. You can't have them after a certain time. You have to have enough fiber in your diet to be able to avoid, because you have to have a bowel movement, right? I mean, if you don't have a bowel movement, then you're really in trouble. So you have to have a bowel movement. So you have to get a lot of exercise. You have to have fiber. If you're doing bowel training, you put a patient on the commode the same time every day. If the person sits for any longer than 15 minutes, take them off. It's not going to happen. You don't want any, you want this to be a positive experience for the patient. Okay. All right. Now some monitoring devices we'll talk about. Cardiac vital signs. We're going to monitor the blood pressure, the respiratory rate, temperature, blood gases, EMGs. Pulse oximeter, we know what it does. Pulse oximeter, we get a measurement of SA2, SaO2, sat rate. And normal sat rate is what? Between 95 and 100. Yes, this says 95 and 98, but 95 and 100. And anything below 90 requires what? Anything below 90% requires what? You're going to have an exam next week, I think. So that woke you up. Anything below 90% requires what? Supplemental oxygen, unless what? See, it's no good when I do Zooming, right? I have to be here to yell at you and to ask you questions. Unless what? When can it go below 90? Monica, we were trying to Zoom you.
I know, I just have to just grab my mom's car.
Okay. Unless what? Anybody read what we discussed last time? Or 2 times ago? What's it normal for it to go below 90? Pulmonary patients, COPD, right?
May I have your attention, please? Our college's coronavirus task force needs everyone's full cooperation and adherence to the CDC's COVID-19 guidelines when you are in the building. Everyone must wear a face mask at all times in public areas of the building. no more than 2 people on an elevator at any one time. Everyone should wash their hands frequently, and if you feel ill, please stay home. Thank you for your cooperation.
Okay, so if we have COPD, or we have a pulmonary patient, or a lung transplant, or any of these things, it may be normal to have a set rate of 88. We discussed this already. All right? But if you have a patient that doesn't have any of these things, anything below 90% is not normal for them. So we need to be between 95 and 100. Okay? All right. A pulmonary catheter is also known as a Swan-Ganz catheter. It measures right atrial pressure. Okay, so know that the pulmonary catheter measures right atrial pressure, pulmonary arterial pressure. Okay, and usually they insert it either through the internal jugular or the femoral and vein, or they'll go in the arm, the basilic or the subclavian, and they take it to the pulmonary artery. So it's diagnostic or it's temporary, and it'll measure the right atrial and pulmonary pressure. You don't have to know the numbers. Okay, it's just know what it measures. So we'll provide information to you about the cardiovascular system, and and also information regarding how the patient is doing with the medication, exercise, stress. Be careful if you dislodge, that you don't want to dislodge this catheter. So if it's in the femoral area, so if it's in the leg, you're going to avoid flexion and abduction, and if it's in the arm, you're going to avoid shoulder flexion. Okay, because you don't want to dislodge the catheter. So pulmonary catheter or Swan-Ganz is for central venous pressure and pulmonary pressure.
Professor, can you repeat that again?
Say that again?
Avoid flexion and abduction?
Avoid flexion. If it's in the upper extremity, avoid shoulder flexion. If it's in the lower extremity, avoid flexion and hip flexion and abduction. Yes.
For the oxygen with monitoring, is it also normal to see it in patients who just had heart surgery?
Yes.
A drop in oxygen?
Yes. Okay. So there's where the catheter would enter if they're doing subclavian. Okay. So if you have, you could see that they may do this with people who have circulatory problems, and they find out things like heart failure, lung disease, etc. This is a monitoring device. You can see it's a digital monitoring device, graphic representation of what's going on. And they have these on the wall, or they have them on the patient's bedside. So you can see the SA2 rate, you see the respiratory rate, you see their heart rate. So these are things that if you're working with a patient, you don't need to do that because you could see them come up on the graph. So it's graphic representation. We're going to try to go up to the nursing department. I asked today, I even asked if it was possible to do it on a Friday, since we do have, we do have these Friday things scheduled from 9 to 12. I'm going to find out for you. So if we can go up maybe, because we're going through some little bit more note writing, and we're going to get you guys scheduled to do the CPI. So we'll make sure that the CPI is a clinical performance instrument, so we'll get you trained in that before you go out to clinic. All right, pulse ox, we already said what a pulse ox is. We don't have to say that again. And intracranial pressure monitor, so if somebody's got intracranial pressure, we're going to measure the pressure, the cerebral spinal pressure. So it's, we're going to avoid with these things, if you see anybody with a device, with a monitoring device that measures the intracranial pressure, you're going to avoid a Valsalva. You're also going to avoid, why would you avoid a Valsalva? And isometric exercises. Why would you do that?
Because it increases interthoracic pressure?
Yeah, because when you do a Valsalva or you do Isometric exercise, it increases pressure. It increased blood pressure, it also has a rapid increase in intracranial pressure. Okay? So avoid them. An A-line is inserted into arteries. What arteries do you think an A-line is done in, especially, what, radial, right? Dorsalis pedis, axillary, brachial, femoral arteries. Can be in the forearm, measures blood pressure, or it's used to obtain blood samples without having to continuously puncture a patient or stick a patient to get this information. Okay, so this continuous needle puncture, it'll avoid it. Complications with anything, any kind of needles, but I have it located here. Sepsis, which is an infection, a hemorrhage, fistulas, holes, necrosis, tissue death, aneurysms. Okay? You can exercise with this patient, but do not occlude the line. So do not do a BP cuff over the line or over that arm. So anything that occludes it is contraindicated. Okay? A Hickman is an indwelling right atrial catheter. Okay. This in bold to provide medication. So parenteral nutrition. Parenteral nutrition, I've used that word many times. That's providing medication through a catheter. Okay, so you could do total parenteral nutrition. So that person does not eat or drink anything by mouth. They have medication, and their medication and their food comes through there. Hyperalimentation. So you could use this to remove the blood. It specifically measures central venous pressure. Okay, central venous pressure. And that's what it looks like. Complications, again, this is a PICC line. PICC line is peripherally inserted, and it goes directly to the heart. A PICC line is used when someone is on IV medication for a long time. They insert a PICC line. Okay, so if someone has to be on IV meds for 6 weeks and they want to get these meds through the system as quickly as possible, they don't do an oral antibiotic, they do a PICC line. Okay, unless somebody has other complications. You know, if they're on blood thinning medication, then this may not be the thing to choose. Okay, so if you're on blood thinners, it may be contraindicated. All right, lab reference values. I don't have that here, but all right. So everybody know what a pH is, right? You have a pH in your body, normal, acid, or base. So anything that the acid-base acidosis is anything less than 7.35 is considered acidosis. Anything over 7.45 is considered alkalosis. We're going to try to talk a little bit about, and this is not a respiratory class, but I think that you need to understand the difference between respiratory acidosis and alkalosis and metabolic acidosis and alkalosis. Okay, because there's always a state board question about, is somebody in respiratory acidosis or are they not? Okay, so partial pressure of carbon dioxide, that's important to us, and HCO3 is an alkaline substance which is in the blood. We're not going to look at the oxygen or the PO2, the PaO2, or the O2, but these are the definitions of what they are. All right, respiratory metabolic acidosis and alkalosis. The acid base, again, I said if it's under 7.35, you're in acidosis. It's over 7.545, you're in alkalosis. So we're going to look at the pH value. That's an important thing for us to look at. The pH value, the CO2, and the HCO3 to determine whether somebody has either respiratory or metabolic. So if somebody's in respiratory alkalosis or acidosis, we're going to look at the CO2 level. Okay, PaCO2. If somebody is in metabolic, we're going to look at the HCO3. Okay? So if the pH is low and the value is acidic, and if the pH is high, the value is alkaline. If it's a respiratory problem, as I said, then we're going to look at the CO2. That will be out of range. If it's a metabolic problem, we're gonna look at the HCO3. That'll be out of range. So if the pH is high, CO2 is low, then we're in respiratory alkalosis. If the pH is low and the CO2 is high, we're in respiratory acidosis. And I'll show you this. And it can also be compensated or uncompensated, and we're gonna look at normal values. That's how we're gonna determine this. So we're gonna look at the values of CO2, which are between 35 and 45. But we're flipping this when we do our tic-tac-toe method. And the HCO3 is between 22 and 26. You just sent a 6 there. All right. So, look at this picture. Alkalosis on that side, acidosis on this side, right? 7.3 to 7.45, normal. 45, which is on this side, is the PCO2 respiratory, 35 alkalosis, 22 this side for HCO3, 26 that side. Okay? So, let's first get a sheet and set up this tic-tac-toe method. So you have your acid, you have your base, you have your normal acid and base. So how we started with a nice simple tic-tac-toe. Okay. So you see from this picture, CO2 greater than 45 would be placed under the acid column. HCO3 less than 22 would be placed under the acid column. Normals, we talked about, 45 to 35 and 22 to 26. Under the alkalosis or the base column, anything greater than 7.45, and for CO2, anything less than 35, and HCO3, anything greater than 26. Okay? So, let's solve this problem. pH is 7.24. Is that normal?
No.
Is it?
Low.
Okay, so looking at this picture, where should it be?
Should be
Between 7.35 and 7.4.
Where should it be?
top left.
Should it be under acid or base?
Acid.
Should be under acid, right? So we already know we have something in acidosis. We don't know whether it's respiratory or metabolic. Okay. So draw your tic-tac-toe layout. Here you go. Analyze your pH. The pH is acid, right? Since the pH is less than 7.35, we're going to make it acid. We're putting under acidic. Now we look at the PCO2. What was the PCO2? 75. So is 75, looking at this, 75 less than 35 or greater than 45? Greater than 45, so where do we place it? Under the acid, right? And that's what we did, CO2. Now we look at the HCO3. HCO3 is 23. Going back to this picture, is it less than 22 or greater? It should be 22? Oh, 28, I'm sorry, 28, not 22. So it's greater, right? So, now, we're okay with this, right? So far? Just by looking at the pH, just by looking at the graph, we said that our pH is acid, we said our CO2 is acid, and we said our HCO3 is base. So what do we think is happening here? Do we think this is respiratory acidosis, metabolic acidosis, respiratory alkalosis, metabolic alkalosis? This is respiratory because it's CO2. Respiratory acidosis, and is it being compensated for? Since the HCO3 is out of normal, it's considered a partial compensation. Okay? If the HCO3 were normal, the body's not compensating for it. Okay? So, now that you have your tic-tac-toe, you need to figure out what you have. So we just said It's fully compensated, partially uncompensated, or uncompensated. Look at the 8CO3. Since your 8CO3 is basic, the metabolic system is trying to balance the body's system from becoming basic. So it's partially compensated. I didn't want to get into, this is not a full respiratory lecture, so you don't have to know all the ins and outs of respiratory or metabolic acidosis or alkalosis. I just want you to understand the difference, okay? The difference. So it's partially compensated. If the 8CO3 were under the normal comment, it would not be compensated because it's not trying to compensate for anything. It's normal, okay? So, I gave you this one. Consider the following. pH is 7.5. Is that alkalosis? Yes. Right? CO2 is 47. Is that greater than 45? Yeah, so it's in the acidotic column, right? But the 8CO3 is with the pH. Anything that's with the pH is what the problem is. So if it's the CO2 with the pH, it's respiration. If it's the 8CO3 with the pH, it's metabolic.
So this would be a metabolic alkalosis with partial compensation.
Correct. Correct. Okay? So did everybody hear what he said? The pH is 7.5, we have alkalosis, it's a problem respiratory metabolic, it's an alkalosis. We have metabolic alkalosis. Okay? So how about you guys do this? Make your own tic-tac-toe. What'd you get? Anybody?
Partial compensation respiratory acidosis.
What'd you get?
Partial compensation for respiratory acidosis.
Andrew? Everybody? Yes? Chris?
No, I like his answer, yeah. Can you ever have both respiratory and metabolic acidosis, or on the other side, can you have respiratory and metabolic alkalosis at the same time?
I don't know. I don't know, because I'm not a respiratory therapist. But you know what, we could ask Professor Scott. She does a lot of this up in nursing.
How is this clinically relevant to us? Like, what do we do with this information? Like, how do you treat a patient different if they're in respiratory acidosis as opposed to?
Hold on. We have to know the signs and symptoms, okay? And we have to know why it's happening. So if somebody's in respiratory acidosis, that person is COPD. That person may have COPD, and maybe they don't know it. Or maybe they do know it, and we have to recognize that they do have COPD, chronic obstructive pulmonary disease. Their pH is decreased, they're hypercapnia, they have an increased CO2, so they need to get rid of the CO2 because they have an increased CO2. So these people with COPD do things, and we need to teach them things like pursed lip breathing, which you'll talk about next year. But they'll usually hold on to walls and things when they're walking, and they're usually thin and frail because they're using all their energy to just get their lungs to work, and they have to blow out the CO2. So they'll do something known as pursed lip breathing.
Yeah, so isn't that something with hyperventilation too? So yeah, I guess your body trying to bring you back to homeostasis.
Yes.
So it's either
Yes.
bringing more CO2.
So if you don't have enough CO2, then you would use a bag, right? So these people have their symptoms early on. We just need to recognize the symptoms, okay? But we also need to know what the difference between if something's, if it's metabolic acidosis and alkalosis, what's that? Anybody know what metabolic is? Metabolic acidosis and alkalosis? Because because you may see in the chart that somebody has metabolic acidosis or alkalosis. What if I had C. diff? What do you think? Metabolic acidosis. You'll be in metabolic acidosis with excessive diarrhea. If you're excessively vomiting, you'll be in alkalosis. Okay, so these are important to know. When you're looking at a chart, if somebody's suffering from acidosis, then you know that they're pooping a lot, or they have diarrhea. You know they're losing all their fluid and electrolytes that way. So metabolically, they have acidosis, as opposed to an alkalosis, which is from vomiting. Okay, respiratory is associated with the respiratory system. Okay, so late signs, these people may have visual disturbances, confusion, drowsiness, coma. As opposed to hyperventilation, which you talked about, Joe, right? If you're hyperventilating, respiratory alkalosis, pH is greater than 7.45. They're hyperventilating, so they're lightheaded, they're dizzy. So what do? You get them to calm down, you get them to take deep breaths, right? You get them to try to get rid of the CO2. Get more oxygen. So numbness, tingling of the digits, tetany. So they may have convulsions. So these are the difference between the two people. The signs and symptoms of both. Okay. Reference lab values. I'm going to make this pretty simple because when we're going to look at reference lab values, you're going to go over them next year in more detail when you go into cardiac rehab and things like that. But when somebody has a heart attack, the heart muscle releases enzymes. So if the heart has had an attack, the enzymes that become released are within the body system in the blood system for like 24 to 48 hours. So an acute MI, you're going to look at the CKMB, creatine kinase MB. Okay, that's the enzyme that's released from the muscle. So you often wonder how, when you bring somebody to the ER, how do they know so quickly that somebody's had an MI? They look at the enzyme levels. So these enzyme levels will be released immediately once this person has an MI or myocardial infarction, and it'll last for 48 hours in the blood. Later on, when you're going to see them, you'll see that maybe their troponin levels will be increased. Troponin levels last much longer than these. These enzymes last for like 48 hours. Okay? So, and you will get numbers of normal. And you don't have to memorize these numbers because these numbers, there's always going to be a chart that says this is normal, this is elevated. So if somebody has an elevated creatine kinase MB, then you know somebody's just has sustained an MI or a cardiac incident. Okay? RBCs, red blood cells. So these are normals. What's an increase in red blood cell? What's that known as? Anybody know? Do you have an increase in red blood cells? Polycythemia? Polycythemia? Is this a good thing or a bad thing? We have an increase in red blood cells. Is it better to have more? What happens to the blood when you have polycythemia and it gets thicker? So what happens when the blood gets thicker?
Slow venous return or...
Slow return, and it'll also clot. Okay, so you have to worry about clotting in a patient that has polycythemia. How about white blood cells? What's that indicate? Infection. Right, so anybody who has an infection, active infection going on, leukemia, neoplasm, cancer, inflammation, an HIV person or a person that's on chemo. Hemoglobin. Hemoglobin levels 13 to 16 and 14 to 18. So if somebody's got a hemoglobin of 8 or less, what do you think they need to do? And these are important because when you go in and you look at a chart and you look at the hemoglobin level, and you're there to exercise, and maybe nobody's gotten to you yet, and that person has a hemoglobin of 7.5.
I wouldn't exercise now.
You definitely don't exercise this patient, because they
Do they need oxygen?
generally, when your hemoglobin drops lower than 8, they do a transfusion. Okay, a lot of times they do a transfusion. Okay. And important in polycythemia or anemia is the hematocrit level. That's the percent of red blood cells in the blood. Anticoagulation. I'm all out of whack here. These are some drugs for anticoagulation or to prevent blood clots. And heparin is one. Coumadin, warfarin, Plavix, Lovenox, Arixtra, aspirin. These are all anticoagulants. All right, blood thinning. So even Advil is a blood thinning drug. Okay, you have to be careful with somebody who is on blood thinners because they bruise easily, and they also bleed quickly, and it's hard to control. You know, so if they have an injury, you want to make sure that you provide direct pressure to stop the bleeding. Okay, but Eliquis is a big one too. And there are all these name brands, but usually when you have lower extremity surgery of some sort, they put you on an anticoagulant so that you don't clot. They'll first put you in these compression pumps, and they'll give you a TED stocking. Remember what TED stockings were? Thromboembolic deterrent stockings, right? They'll put you in them. They'll put you in a pump. They'll ask the therapist to do ankle pumps. They'll get you ambulatory, and they'll put you on some kind of anticoagulant. All right. Whether it's an aspirin or something else. You know, if they feel that you need an injectable, they'll send you home with Lovenox usually. And Lovenox is an injectable. They just pinch up the belly skin and just, you do it yourself. The patient does it himself. They're taught how to do it to prevent blood clots. Sometimes they do it about 7 days after surgery, then they stop. All right. So the INR. What the INR does, and that's established by the World Health Organization, and that reports the results of blood coagulation or clotting. Okay, so that's what that does. So if you have prothrombin time monitors the time to clot, and normal is 0.8 to 1.2, greater than 4, no resistive exercises. Greater than 5, no exercise at all. So the higher the INR, the longer the blood takes to clot. So you have to establish an INR, especially somebody who's on some kind of an anticoagulant. Okay? You need to monitor this, the blood pressure, etc., in order to make sure the patient is safe when you exercise them. So you have to know their INR. So if you see their INR chart and it's greater than 5, you know you're not going to exercise them. All right? These are normal values, 0.8 to 1.2. All right. Feeding devices. An NG tube, you see the NG tube right into her nose. It goes into her nose and to the stomach, and it's used for feeding. Obtain information about stomach gases, etc. G-tube inserted directly into the stomach. Intravenous feedings, you have an infusion pump, and the infusion pump is attached to this pole, and you have whatever bag is, if it has saline in it or it has medication in it, it's delivered via catheter into the patient. Complications with IV. So infiltration of any sort. Erythema. What's erythema? What's erythema? Redness. Redness. What's cellulitis? Anybody? It's an infection. It's a bacterial infection. So it'll get red, puffy, sore. Cellulitis, phlebitis, inflammation of the vein. Okay, but cellulitis is bacterial infection.
I have a question. Cellulite, two different things?
Yes, yes. Cellulitis is an infection. Cellulitis, pockets of that fat. Yeah, I don't know exactly what else is in cellulite besides fat. But it's different, yes. Cellulitis. Okay, complications also, air embolism. So you can get air into the line, right? Decreased blood pressure, cyanosis, it turns blue. Swelling around the site, any of this stuff can happen. Allergic reaction, a systemic infection. Somebody's got a systemic infection, what do you think the most important thing for you to do to determine that is, before you could even do blood work? Because that's what you need. You need blood work, and the blood work will show you a high C-reactive protein level, and then, or a high SED rate, you'll know that they'll have an infection. Also, taking a person's temperature, right? Because if you take a baseline temperature, and the person's 98.6 and they come in with a 101 or 100, you know that they have an active infection. All right. Oxygen delivery, nasal cannula. Nasal cannula is most common. You see two little prongs they put in the nose. And when you put these on patients, they go around the ears and they go into the nose. Many times you go into the room and the prongs are over here. And they say, I can't breathe. Well, it's because they don't have the nasal cannula in their nose because they don't understand that. So you just put it back. Okay, here's a nasal cannula also. Oral nasal masks. These have like a small hole in the front of it to help expel air, but it's when you have a greater concentration of oxygen. Tracheostomy is a hole that's put, maybe permanent. Incision is made right into the trachea itself, and you can have a permanent tracheostomy or a temporary tracheostomy. You can wean a person off the tracheostomy, or you could leave the stoma there, which they do in a lot of times with patients that have cancer. And the stoma is there, and they cover the stoma. I'm sure you've seen it with some kind of a mesh or something to protect it. And some cancer patients, and I had a talk one time in the American Cancer Society, and I saw at break time, the patient came out and smoked through their stoma. I've had a patient lose a tongue in my hand from smoking.
What?
Because I had to work with they had a radical neck, and I had to work with their neck and their mouth, and their tongue fell out.
Stop.
Necrosis, yeah.
What do you do there, huh?
Not signing up.
Part of their tongue. So, if anybody's a smoker, think
No.
twice about it.
Does it wiggle around?
Oh, well, I worked inner city, so.
What have you seen, man? You've seen everything.
Inner city, so the feet, toes came out, part of the hand came out in the whirlpool. It's inner city. Gunshot, half the face. That's exciting though. It's better than, not exciting, it's
Engaging.
It's engaging, exciting, and it's rewarding because, you get somebody back to some kind of function, which is really, right? It's difficult to work inner city, but it's very rewarding because patients have real problems. I'm not saying that somebody who has a hip replacement or a knee replacement doesn't have a problem, but generally their life, is something that's normal after that. So, ostomy devices, surgical opening in the abdomen, the ileostomy. What's the difference between the ileostomy and the colostomy? Where's the ileostomy? In the small intestine, right? And the colostomy is in the large intestine. So they have a stoma or a hole, and this stoma is actually covered with a plastic bag, and this plastic bag has a pouch, and this pouch collects wastes. So if somebody has to have an ostomy bag, they're collecting their feces through this bag. Okay? And there are people that you're around that you don't even know have it because they keep it so clean. Because one of the worst things you think about is the fact that you're going to smell it. So they're very, very careful about the fact that they have this ostomy bag and they keep it clean. Monica, you know somebody who has one?
Actually, we see it at Robert Wood Johnson in Norway.
So. And this is what it looks like, and this is what they cover it with. Okay, so they put it in here, and they clean it, and they put it back on to collect the feces, and then, and this can be permanent too. Can be temporary, it could be permanent. I mean, there's people that really have terrible things going on in their lives, you know, and they deal with them. Yes.
With the ileostomy, would there be an issue with nutritional, like, deficiencies?
Yeah, yeah, but that's why they're on all kinds of things like Ensure and Gatorade and all kinds of supplements. And if they need a supplement, other than something they can take in, they get an IV license. Okay. Fractures. We'll just talk a little bit on the fractures. So when we do traction, and I'm not talking about the traction that I would do if you were going to lie on the table and I was going to pull your leg out, or I was going to do traction for your back, but traction generally, when we talk about, we're going to align fractures with traction. There's a Thomas splint traction device. I'll tell you that in 1 second. We can use traction, though, to decrease spasms, and that's a traction that's portable traction for your cervical or your lumbar spine. We could use traction to keep somebody in bed by immobilizing them. There's balance suspension traction, skull traction, internal fixators and external fixators. All right, so you all know that's an external fix, right? So it's got some Steinman pins, and it's got this cage that goes around it that attaches. The cage just holds the pins in place. Okay, it looks horrible. I mean, it looks, you know, first time you see it on a patient, you say, oh my God, look at that looks horrible. What am I going to do with that patient? Cage is really just holding the pins in place, and the pins are what's doing the job. Okay, so what do we worry about with this patient? What do we worry about? Here, where the pins are. Okay, because we want to keep that area clean. So we tell the patient how to clean it, and we take a 2x2 or 4x4 and open it up, put some saline around it, and make sure they're able to clean their pin site. Okay, because you don't want any infection. Because what happens to the body, what does the body normally do? It encapsulates everything. So you're going to make sure there's no crusty, crappy stuff around the pin site. Make sure it's clean. All right, so you're going to teach your patient how to do that. Internal fixation, you place it in. They could do rods, they could do pins, they could do screws, they could do plates, any kind of a fixator. Intermedullary rod. Halo traction is done in somebody who has a cervical spine, maybe an incomplete cervical spine fracture. So if somebody's got an incomplete cervical spine fracture, you do not want them to move their head, because if they move their head, they will have a complete cervical fracture. Okay? So if we want to stabilize the cervical spine, I'm going to need to put a jacket or a harness on them, a vest, and attach it with uprights to burr holes that are drilled in the skull, and then a halo to hold it all in place. Okay? This is really, really kind of traumatic for a patient, because, you know, they can't move. So what do you think happens after 6 weeks, or, well, in these cases, maybe 8, 12 weeks after the cervical spine is stabilized? They take the jacket off, and they remove the pins with a drill. Right when the patient's in the room, or the patient comes to clinic, and they just, if they have a hand drill, they do it, or if they have a hydraulic drill, they just pull them out. And what happens, you get a little bleeding at the site, not a lot, but you do get some bleeding. But what do you think you need for the patient? So you're in a neuro clinic with the doctor. He says to you, okay, I want you to help me. I'm going to take this halo off of them. You grab it when it starts to come off. You grab the halo, and then you help me with the patient. What do you think you're going to need?
You're going to stabilize the neck. You're going to stabilize the head because of the fall.
You're going to need some kind of a neck brace, right? Because the head is going to fall. right? The head's been held up for 12 weeks, or whatever, or whatever's been. And plus, it's had no range of motion, right? In order to see when you're like this, you need to turn your body. You can't turn your head. Okay, so imagine having this kind of patient, and you see these people, multiple injuries. Again, I've had many, where they've had a cast on one leg, a cast on an arm, and a halo traction. You know, they can't look down the stairs like this. You have to get them downstairs. So you have to be creative. All right. Types of beds we're not going to talk that much about, but you have to know that there's one other thing I want to tell you. Oh yeah, about traction. Balance suspension traction. I don't know if I have a picture of it. No. But a balance suspension traction. It's called the Thomas splint. Thomas traction.
It's,
it's
it's at the end of the slides.
It's in there?
It's toward the end.
Oh, okay. Skeletal traction with a Thomas splint. What's the importance of this? This is what I want to tell you, yeah. What's the importance of this? So this is a balance suspension traction. Patient has a Steinman pin again, and the traction, you can see the traction at the bottom of the bed, the weights, pulling on the limb to align the limbs. What does this patient have that other patients won't? A trapeze bar. Okay, so the trapeze bar for that patient is used. Can you see the trapeze bar? So this trapeze bar is used for that patient because that patient can't get out of bed. This suspension traction is on 24 hours a day. This patient can't get out of bed. Okay, so this bar is used for things like patient can use that one leg and do a bridge, right? So the nurse can help clean the patient as well as change the bed, right? Can you use this for therapy?
Yeah.
Sure. You could use this as an assisted device to help you with therapy, or you could use this as a resistive device if you're working on upper extremities, general conditioning exercises, right? Just be cautious when somebody has this, not to do everything with the trapeze, because once this person goes home, they will not have a trapeze. Okay?
So why would you put someone in this as opposed to the other device? Like if they're physically unable to get out of bed, or like?
No, these people can't get out of bed. They do not want them out of bed because this traction is 24 hours.
Yeah.
I was in this when I was 16 for 10 weeks. 10 weeks.
You can't get out of that. 10 weeks.
Wow.
And I couldn't, my head couldn't be elevated any more than 30 degrees. I couldn't sit up.
What happened with that?
I had a motorcycle
That
accident.
was the accident? Okay.
And I had a compound femoral fracture. So at that time, now what they would do is an intramedullary rod. And they would send you home in probably 3 days. But then they had to do this. Yeah.
What's the purpose of it? Why would you use this as opposed to like internal fixation?
Why did I have this as opposed, or
No,
why
so
would
why
they
would
use
you-
In
this?
general, why would you have
Why would
this?
you use that why wouldn't you just do it?
They don't use it that much anymore.
Okay.
But they may still do it if somebody's got like compound comminuted fractures, and they need to stabilize the person. They may still do this.
So this is just to immobilize it?
Yes.
Alan Smith.
I was just going to say that.
Yeah.
Okay, so beds, let's see. Don't worry about beds, they're not gonna ask you about beds, but there's different types of beds. Clinitron, these beds sway back and forth, these post-traumatic beds, and they can give you seasickness. They have side rails, they have, call bells, etc. Those are the important things about beds. You could, the other important things about beds, this striker frame bed turns a patient. It's good for skeletal traction and after a spinal fracture. So, but, you know, who wants to lie prone for so many hours of the day? But you may see this. A clinitron bed is, this has silicone beads in it. So the importance of any bed is the mattress, not so much the bed, right? It's the mattress. And why is the mattress important? For skin breakdown, right? So this will accommodate to a patient's crevices and nooks and crannies, etc. When it's on, it feels like it's a waterbed. So these beads will oscillate. It feels warm, it has a temperature associated with it, it feels warm, it's comfortable. Problem with it is that in order to work with a patient on the bed, you have to turn it off, and then it gets hard. Okay, the other problem is that it can be cut very easily, can be damaged very easily, it's very high. I don't know if they're really, have they developed any that go up and down, but this one, the ones that I've seen do not, so they're at one level. So it's uncomfortable to do a lot of the activities that you need to do when the bed is so high. And the advantages of the patient, disadvantages the patient can sweat. So these are indications for spinal cord, and number one reason, to prevent pressure sores. Okay? Post-trauma mobility beds, they can move and they have bolsters, so you can position somebody. These have little bladders that will accommodate to the weight bearing of the weight of the patient. So they have sensors in the bladders that accommodate to the weight of the patient. So if there's too much weight, if there's too much pressure on one side, it'll shift automatically, so the patient doesn't suffer the consequences of a pressure sore. Okay, and these are the least. Egg crate mattress is just the least beneficial. Okay, I don't know if any of you have ever been in bed for a period of time, but if you've been in bed for longer than a day without moving, you know how you feel, right? Something gets sore here, something gets red here, right? So these are the least accommodating. So if somebody is in a hospital, and they're going to be in for a period of time, you want to make sure that they have a mattress that accommodates to their body, specifically to their
So it
body.
seems like-
And you have to know the weights, and you have to know the height of the patient. You put this all into this computer, and it accommodates. Yeah.
Just when you see these stage 2, 3, 4 pressure ulcers, is that just a neglect of the healthcare workers in that area, or is this nothing you could do? They're
Well,
going to be laying
Not
down
real,
for a while.
not really. However, remember what we said about, there's a lot of things that cause those pressure sores: friction, maceration, incontinence, all that kind of stuff. Remember we said also that Christopher Reeve died of a pressure sore. He had round-the-clock care. No matter what you do, if somebody's not moving, they're not moving. I mean, you're going to try to be as religious as possible with that every 2-hour movement, but something's going to break down somewhere. I mean, it's I had an aunt who had multiple sclerosis, and at the end she didn't move at all, and my uncle had to carry her everywhere. And just till maybe the very last month or so, she started to develop little ulcers. But he said, I'm doing everything I can, I'm moving her as much as I can, nothing's working. So your body starts to break down. Okay, and then finally, what's a PCA? Patient-controlled anesthesia. So you get morphine, you put it in the pump, and you tell the patient every time you feel some pain, hit the pump. You ever had
Yeah,
it?
I've had that before.
Okay. What you probably didn't know is that every time you hit it, you don't get a bolus.
I've never used it. Yeah,
Okay.
I didn't hit it.
I also have that, and I was talking to my sister about it, and she's like, it actually doesn't work, right? And I was like, what? But apparently, I broke it, she's like, I kept pressing it, and I was so and she was like, yeah, it actually doesn't.
Yeah, it's controlled, but a patient doesn't know that.
They told me I couldn't use
So
it.
sometimes it's like mind over matter.
Yeah.
Okay, it hurts, I'm going to push it, and they hear beep, and they think, oh, okay, it's working, I feel better
They
now.
told me once every 4 to 6 hours I
But
could use
but
it.
there's a certain amount of bolus that will be delivered over a certain amount of time, and there's a time when it stops. So you can't keep hitting it to get a high. So patient control anesthesia. And finally, dialysis. So dialysis, what do you worry about with dialysis? You have a shunt in the hand, in the arm, in the forearm, and the blood is pumped out of the body into something known as a dialyzer, which I'll show you in a second. and that takes all the waste out of the blood and then returns it, cleanses it, and it returns it back into the body via some kind of a catheter or shunt. Okay? And that's a hemodialyzer. So the use of shunt pumped through the body is done every 2 to 4 hours, about 3 times a week. So when this person has a shunt, it's indwelling. You're going to see it. Do not take a blood pressure over. Do not exercise. Do not occlude this side. Be cautious. Okay? And that's what it looks like. All right. Good. Okay.
So things like dialysis, is that used for like metabolic waste? Or is it like, I'm not actually too sure what kind of dialysis.
Well, there's peritoneal dialysis also. There's hemodialysis and peritoneal dialysis. You're thinking probably more of peritoneal.
All right, guys. See you later.